welcome to my channel. So this time I'm providing you an additional Impella training based off the online curriculum that was given by Abiomed. So the Abiomed, if you have not done their training curriculum via their website and you need to take care of a patient with Impella, so I'm providing you this video. Pretty much everything in the Abiomed website is incorporated in this video. So just a disclaimer, the video training here is based off Abiomed curriculum. Okay, so what would be the first video looks like? So it's a 30 minutes long, and I highly recommend for you to have your notebook to take notes of some of the most important information in there that you need to know, such as PURGE system, what is AIC, what is Impella position, what do you do if there's a migration of the catheter, what do you do if the patient just got to ICU from cath lab. So we normally ordered for echo, and then you do an echo to verify placement. And then of course, if the patient is moving a lot and you think it's kind of migrated your catheter, so you need to again get your echo tech to do an echocardiogram. So these are part of your workflow, so you have to make sure that they can actually, that you have the access to your echocardiography department. And then what is in the home screen, such as history, infusion, history, things like that. Okay.
A 5.0 and LD technology overview. The first course in the Impella 5.0 and LD training program. This course provides an overview of Impella 5.0 and LD technology, system components, and principles of operation of the Impella 5.0 and Impella LD catheters with the automated Impella controller. Please take a moment to review the Impella device indication and safety information. When done, click anywhere to continue. This training will begin with an overview of the Impella 5.0 and Impella LD heart pump technology and system components. The automated Impella controller, which is the interface for monitoring and controlling the function of the Impella heart pumps and PURGE system, is introduced, as well as how the differential pressure sensor is used to monitor position and calculate flow. Take a moment to review the learning objectives. When done, click anywhere to continue. The Impella heart pump family of products are catheter-based devices, providing hemodynamic support while allowing the heart to rest. This training will focus on the Impella 5.0 LD heart pump and the automated Impella controller. As you proceed through this course, you will notice many similarities between the Impella 2.5, Impella CP with Smart Assist, Impella 5.0, Impella LD, and Impella 5.5 with Smart Assist heart pumps, system components, and principles of operation. You will also notice some key differences. Let's begin with an overview of the Impella 5.0 heart pump features and benefits. The Impella 5.0 heart pump is a 21 French microaxial pump on a 9 French catheter-based platform that requires a low anticoagulation regimen. There are several options for the single access point, and there is no need for a septal puncture, priming, or multiple large bore cannulas. The Impella 5.0 device directly unloads up to 5 liters per minute from the left ventricle to provide ventricular unloading. This animation shows the insertion of the Impella 5.0 heart pump introduced through the patient's axillary artery. The Impella 5.0 device travels through the axillary artery, down the ascending aorta, across the aortic valve and into the left ventricle. The inlet area of the Impella catheter sits in the midventricular space, and the outlet area sits in the ascending aorta. An integrated microaxial impeller inside the distal end of the cannula rotates to pull blood from the ventricle into the aorta. This action provides hemodynamic support to the patient by increasing cardiac output. Like the Impella 5.0, the Impella LD heart pump is a 21 French microaxial pump on a 9 French catheter-based platform requiring a low anticoagulation regimen. Surgical placement of the Impella LD device is less invasive than other technologies, with direct surgical placement through a single access point in the ascending aorta. There is no need for a septal puncture, priming, or multiple large-bore cannulas. Like the Impella 5.0 device, it provides ventricular unloading. The Impella LD heart pump directly unloads up to 5 liters per minute from the left ventricle. The Impella 5.0 and Impella LD heart pumps are intravascular microaxial blood pumps that support a patient's circulation. The Impella 5.0 device is inserted through the axillary or femoral artery and guided into the left ventricle. The Impella LD device is inserted directly through the ascending aorta and into the left ventricle. The differential pressure sensor is used to monitor catheter position and calculate flow. This feature differentiates the Impella 5.0 and LD devices from the Impella 2.5 and Impella CP devices, which uses a direct rather than differential pressure reading for placement. The catheter shaft on the Impella 5.0 is 9 French in diameter and has centimeter markings incorporated to help aid in positioning and position verification. The repositioning sheath is 9 French. A blue suture pad provides a place to suture to the skin or to secure with a stat lock device. A sterile sleeve attached to the repositioning unit allows for sterile repositioning of the device if required. The red Impella plug has a memory chip to retain information should a transfer to a new automated Impella controller be required. The clear sidearm is where the PURGE solution is connected, which will be discussed in further detail later in the training. The differential pressure sensor and other parts of the Impella 5.0 device are discussed in more detail in later courses in this training program. This figure illustrates each component of the Impella LD device. Like the Impella 5.0 device, its key components include the inlet area, where blood is drawn into the cannula, the outlet area, where blood exits the cannula into the aorta, and the differential pressure sensor, which is used to monitor catheter position and calculate flow. There is no repositioning sheath on the Impella LD. These and other parts of the Impella LD heart pump are discussed in more detail in later courses in this training program. When the Impella device is properly placed across the aortic valve, it transports blood in the same manner as the native heart. It pulls blood from the ventricle through the aortic valve and into the root of the ascending aorta. This flow reduces ventricular and diastolic volume and pressure and increases the mean aortic pressure and flow. The rotation of the impeller inside the Impella cannula creates a negative pressure that pulls blood through the cannula from the inlet area to the outlet area. The rotational speed is proportional to the flow. The faster the Impella rotates, the higher the flow produced by the Impella catheter. The operator uses the automated Impella controller to control how fast the Impella rotates by adjusting the performance level, or P level. Here are the P-level flow rates for the Impella 5.0 and Impella LD catheters. The flow ranges from 0 at P0 to 5.3 liters per minute on P9. At each performance level setting, there is a range of flows, which is dependent on factors such as preload and afterload. The Impella is a preload dependent device, meaning that volume in the left ventricle is necessary for it to achieve optimal flows. A high systemic vascular resistance could also impede flows from the device. If flows are not within range for the set P level, adjust the settings until they are. Additional volume may be required if preload is not optimal, and reducing or discontinuing the use of vasopressors may also be beneficial to increase flows. Next, let's look at the features and function of the automated Impella controller. The AIC performs three functions that are vital to the operation of the Impella catheters. It provides an interface for monitoring and controlling the function of the Impella heart pumps. It provides purge fluid to the Impella devices. It provides backup power when the Impella system is operated away from AC power. With one touch, the controller automatically primes, detects, and de-airs. The large high-resolution display provides insight to catheter function at a glance. The Impella controller is designed for transport via ambulance, helicopter, or fixed-wing aircraft. The automatic purge system automatically adjusts the purge pressure for more efficient patient management. This figure illustrates the features on the front of the automated Impella controller. The display screen displays user information, including the labels for the soft buttons. The soft buttons display open and close menus. The power indicator LED light above the selector knob indicates the power status of the Impella controller. The selector knob is a rotating push button that can be turned clockwise and counterclockwise to navigate through menu items. To make a selection, push in the middle of the button. An audible beep confirms the selection. The catheter plug is the connection point on the controller for the connector cable. The purge cassette door is a spring-loaded door that opens to provide access to the purge cassette when you press the door release button on the left side of the Impella controller. The soft buttons on the automated Impella controller are labeled on the display screen. The labels change depending on the type of screen displayed. This image shows the default soft button labels that appear when the Impella device is running. Mute alarm allows you to mute or silence active alarms and clear resolved alarms. The mute alarm indicator, a bell with a red X, replaces the label when an alarm is muted. Flow control allows you to set the flow rate to one of 9 P-level settings, P0 through P9. The auto setting is not an option for the Impella 5.0 or Impella LD catheter. Display opens the display menu for viewing waveforms and navigating to other display screens. Purge menu opens the purge menu for selecting various purge procedures, including changing the purge fluid and the cassette, and de-airing the system. Menu opens a menu of options related to controller settings, zeroing the placement signal, alarm history, timed data recording, and starting a case. When the display soft button is pressed, the option to toggle between 4 different screens is possible: placement, home, infusion history, and purge. The option to transfer to standard configuration is not available for the Impella 5.0 or Impella LD. The placement screen displays real-time operating data for the system. This is the default screen once case start is complete. The screen displays the placement signal waveform and, below it, the motor current waveform. These waveforms are useful for determining the location of the catheter with respect to the aortic valve. The home screen displays a heart pictogram and, to the left of the heart, an Impella catheter position indicator message. The heart pictogram provides a visual representation of the current Impella catheter position. It may be overlaid with a translucent yellow question mark when the controller cannot determine catheter position or the placement monitoring is suspended or disabled. The purge screen displays purge system information. In the central display area of the screen, the purge flow rate and purge pressure are displayed as a function of time. To the right of the waveforms, the current purge flow rate and purge pressure are displayed. The pressure sensor on the controller reads purge pressure from the purge disc and automatically adjusts the purge flow to stay within the specified range. The automated Impella controller issues an alarm if purge pressure is too high or too low, or if it detects a blockage. The infusion history screen displays the infusion volume as well as the amount of heparin and dextrose infused each hour. The current time period is displayed at the top of the list. The calculations begin when the case start procedure is completed and the flow rate is greater than 0 liters per minute. Regardless of what screen you are on, there are common screen elements that will be displayed at the bottom of each automated Impella controller screen. The Impella flow area displays a mean calculated Impella catheter flow in liters per minute, as well as the calculated flow during systole and diastole, as represented in the max-min display. The circular catheter operation icon rotates when the Impella catheter is running. In the PURGE system area, the PURGE system marquee scrolls from left to right when the PURGE system is operating. The current PURGE flow is displayed in milliliters per hour, as well as the current PURGE pressure. The Impella system requires a PURGE system to deliver a rinsing fluid to the Impella catheter. This rinsing fluid, also called PURGE fluid, helps to prevent blood from entering the motor. For the automated Impella controller, the PURGE system consists of an integrated infusion pump, PURGE disc, and PURGE tubing. Inside the Impella motor, the impeller shaft spins to pull blood into the Impella cannula. For this spinning motion to occur, there must be a very small gap within the bearings and between the motor housing and impeller shaft, as shown here in yellow. To prevent blood from migrating into this gap, a rinsing PURGE fluid, typically 5% dextrose or glucose, is infused from the clear sidearm through the guiding catheter and the motor, exiting just behind the impeller. This forward flow of PURGE fluid forms a pressure barrier. The PURGE fluid deflects the blood that the impeller is pulling through the cannula, preventing it from entering the motor through the gaps. A continuous flow of PURGE fluid throughout the support period is needed for the impeller system to maintain this pressure barrier and protect the Impella motor. There are two components to the Impella catheter PURGE system. The first is the PURGE fluid, preferably 5% dextrose in water with heparin. It provides the rinsing action that prevents blood from entering the motor. The dextrose concentration is proportional to the viscosity of the PURGE fluid. The lower the dextrose concentration, the lower the PURGE fluid viscosity. The higher the dextrose concentration, the higher the PURGE fluid viscosity. The dextrose concentration, or viscosity of the fluid, is a factor in determining what flow is needed to maintain a safe pressure barrier and prevent blood from entering the motor. It is recommended that heparin is added to the PURGE fluid. In the event that blood migrates into the motor gap, the heparin will help maintain the patency of the PURGE pathway. The second component is the PURGE cassette, which is an integrated infusion pump which delivers the PURGE fluid to the Impella catheter and motor. The pressure sensor on the controller reads PURGE pressure from the PURGE disc and automatically adjusts the PURGE flow to keep the PURGE pressure within the specified range. The automated Impella controller issues warnings if PURGE pressure is too high or too low, or if it detects a blockage. The infusion history screen displays the infusion volume as well as the amount of heparin and dextrose delivered each hour. This is calculated based on the concentrations that are entered by the user and the PURGE flow rate. The current time period is displayed at the top of the list. The calculations begin when the case start procedure is completed and the flow rate is greater than 0 liters per minute. It is important for the caretaker to account for the heparin being infused by the Impella system into the total heparin patient dose. While caring for a patient with an Impella device, it is important to account for the heparin that is delivered through the PURGE system. This dose can be found on the automated Impella controller by switching to the infusion history screen on the display menu. An ACT of 160 to 180 seconds is recommended for all patients while on Impella support. For some smaller patients, this ACT may be achieved by just the Impella-delivered heparin, requiring no additional systemic heparin to be delivered. For the first 24 hours, it is recommended to monitor ACT levels every 3 hours. In situations in which excessive heparin is being administered through the PURGE system, it would warrant the reduction of heparin. As always, the Abiomed Clinical Support Center is available to answer any questions regarding the Impella-delivered heparin. To determine whether the Impella device is properly positioned across the aortic valve, the automated Impella controller evaluates whether the placement signal is pulsatile or flattened. The placement signal is displayed on the placement screen. It is generated by the differential pressure sensor on the cannula of the Impella 5.0 or LD heart pumps. The placement signal is pulsatile when the catheter position is correct and flattened when the catheter position is not correct. The electronic differential pressure sensor is a flexible membrane integrated into the cannula of the Impella 5.0 and LD catheters. It generates the placement signal that is used by operators, as well as the controller's placement screen and alarm algorithms to monitor catheter position and calculate flow. One side of the sensor is exposed to the pressure of the blood outside the cannula. When the catheter is correctly positioned, this is aortic pressure. The other side of the sensor is exposed to the pressure of the blood inside the cannula, which is ventricular pressure when the catheter is correctly positioned. The sensor generates an electrical signal that is displayed on the automated Impella controller as the placement signal. The pressure sensor membrane flexes when the pressure on one side is different from the pressure on the other side. In doing so, it generates an electrical signal proportional to how much the membrane is flexed. As you can see on the graph, left ventricular pressure varies from 0 millimeters of mercury during diastole to 120 millimeters of mercury when the heart contracts in systole. Aortic pressure peaks in the same manner during systole, but does not drop as low during diastole. When the catheter is correctly positioned across the aortic valve, the outer surface of the sensor is exposed to aortic pressure and the inner surface is exposed to ventricular pressure. The placement signal is the difference between these two pressures. Expressed mathematically, the placement signal is equal to aortic pressure minus ventricular pressure. Therefore, during diastole, when the pressure in the aorta is significantly higher than the pressure in the ventricle, the difference is great. As both pressures equal out during systole, the difference gets smaller. This fluctuation with the cardiac cycle produces a pulsatile placement signal. When the Impella 5.0 or LD device is correctly positioned, the pressure difference across the sensor generates a pulsatile placement signal. When the Impella device is not positioned correctly, and there is little difference between the pressures on each side of the sensor, the placement signal is flattened. The home screen displays a heart pictogram and, to the left of the heart, a positioning message. The heart image provides a visual representation of the current Impella catheter position. The controller evaluates the placement signal and motor current signal to determine the catheter position. The heart image may be overlaid with a yellow question mark when the controller cannot determine the catheter position is wrong, or placement monitoring is suspended or disabled. In these situations, imaging should be used to determine the position of the Impella cannula. Placement of the Impella catheter is discussed in another course in this training program. For additional information, training resources, and to download the Impella Instructions for Use Manual, go to the Abiomed website. Search Impella app from the Apple App Store or Google Play to download the Impella app.
Welcome. And the second video will talks about what do you do when you're admitting a patient from cath lab to the ICU. So again, there's a lot of things in the video that I want you to focus on and take some notes, because placement of the catheter, purging, solution, and ACT, actual clotting time, are some of the things that they discuss that you need to know. Migration of the Impella catheter, what do you need to know about that? How can you determine if there is a migration of your Impella catheter? What would be some of the symptoms of suction? What kind of alarm would you get? So again, I would like for you to pay attention on the videos that Abiomed provided. When the urine of the patient turns red, that's hemolysis. What do you do? How do you maintain ACT, actual clotting time, 160 to 180? And they want you to understand the calculation for how to calculate systemic IV heparin rate, because there's some formula in there. So I want you to really pay attention. And what happened with the high purge pressure? There are some checklists and to-do list in there that you need to take some notes on what to do next. What about the low purge pressure? So they have the checklist provided in there and they tell you what to do next. What about if the patient is going to OR for either explant or surgery? So usually Impella device in OR for surgery, what do they do with the machine? So they might not know what to do with that. So you need to be the subject matter expert there, because you're transferring your patient from ICU to OR. Okay, so you need to pay attention with the video. And what about if your patient develops heparin-induced thrombocytopenia? So Abiomed recommends something for us to do. I think they want us to report it. There are some criteria to make it more resolute that it is indeed HIT. What would be the signs of right side heart failure? Okay, and what do you do during CPR? So what do you do during CPR? Defibrillation. What would be your next step? If your patient is going for, if your patient is in the weaning process of Impella and explant. So please, I want you to check on all this and take some notes. And I thank you for your time.
Welcome to Impella 5.0 and Impella LD Patient Management Topics, the next course in the Impella 5.0 and Impella LD training program. This course provides an overview of managing the automated Impella controller and patients with the Impella 5.0 or Impella LD technology. Please take a moment to review the Impella device indication and safety information. When done, click anywhere to continue. This training will cover topics focused on the patient supported with the Impella catheter and include how to monitor the Impella device placement and ensure it remains correctly positioned after insertion, managing the PURGE system, supporting the Impella while in the OR, general patient management considerations. Take a moment to review the learning objectives. When done, click anywhere to continue. You will get the most out of this course if you understand how the Impella catheter works and the information displayed on the automated Impella controller, which was presented in the overview module. Let's review. a patient is transferred to the ICU with an Impella 5.0 or Impella LD, there are a number of proactive actions and processes to follow to help avoid potential issues. If your local Abiomed representative is not present, call the Clinical Support Center to help check your patient in. The Impella 5.0 patient check-in consists of the following assessments. Ensure the TUI valve is locked finger tight on the repositioning sheath. The centimeter marking that is visualized through the sterile sleeve closest to the sheath should be documented. Assess the patient's overall volume status. If suction alarms are occurring, aim to maintain a CVP of at least 10 millimeters of mercury. Document the urinary output, both color and amount. It will be important to monitor this for potential signs of malposition while on support. A baseline echo should be ordered to verify that the inlet of the Impella catheter is 3.5 centimeters from the aortic annulus. The waveforms on the automated Impella controller may not show that the Impella is in too far right away. If dextrose, 5% in water with heparin, 25 units per milliliter is not already hanging, this should be ordered from the pharmacy. If any alarms are present, these should be addressed. When the Impella device is properly placed across the aortic valve, it transports blood in the same manner as the native heart. It pulls blood from the ventricle through the aortic valve and into the root of the ascending aorta. This flow reduces ventricular and diastolic volume and pressure and increases the mean aortic pressure and flow. Unloading the left ventricle by reducing left ventricular and diastolic pressures and volumes reduce wall tension, microvascular resistance, and increases coronary perfusion. This results in overall improvement in oxygen supply while simultaneously reducing oxygen demand. Some concepts to keep in mind when caring for a patient with an Impella device. To pump blood, the Impella heart pump must have enough volume in the ventricle to prevent suction and support Impella device flow. Low volume could precipitate a suction alarm. If this is the cause, volume infusion could help remedy the situation. If a Swan Gans is in place, the cardiac output displayed on the bedside monitor is a calculated flow of Impella device output as well as native cardiac output. Subtracting the Impella device flow from the cardiac output displayed should be the contribution of the left ventricle. The native heart will compete with Impella device for volume, likely resulting in left ventricular unloading. The device is afterload sensitive. High systemic vascular resistance, or SVR, can lead to reduced flows from the device. The Impella device creates forward physiologic flow. However, the flow from the outlet creates forward thrust, much like the motor on a boat. The Impella heart pump, which extends from the groin all the way to the left ventricle, has a tendency to be drawn deep into the left ventricle. After insertion, expect inward migration and plan accordingly. One of the most effective means of preventing migration and maintaining proper position is to remove catheter slack and carefully position the inlet area 3.5 centimeters below the aortic valve. In this position, the inlet area should be unobstructed and the outlet area is above the aortic valve. The inlet and outlet areas are positioned to avoid the anterior leaflet of the mitral valve. When the Impella device operates at high flow rates, the catheter is pulled into the ventricle. The best method for preventing inward migration of the Impella device is to remove excess slack from the catheter after placement. It is also important to tighten the TUI Borst valve after positioning the Impella device catheter and note the catheter position. If the patient is very active or uncooperative, immobilizing the leg can help prevent catheter movement. To maintain proper Impella device position, obtain a baseline echocardiogram after insertion and arrival into the ICU. Additional echocardiograms should be done after excessive patient movement or in any situation where catheter movement is suspected. Reposition the Impella device using echocardiography if there is any evidence of hemolysis, even if the catheter appears to be correctly positioned. The Impella device will move if precautions are not taken. Expect migration and act accordingly, making sure to never ignore Impella device positioning alarms. To ensure that patients receive the benefits of Impella device support, the Impella device must be correctly positioned across the aortic valve. Monitor the position of the Impella device using the placement screen or the home screen. The automated Impella controller continually monitors the placement signal and the motor current signal. If the controller algorithms determine that the Impella device may be incorrectly positioned, an alarm is displayed in the alarm window. At low flow rates, placement monitoring may be suspended. To address incorrect Impella device positioning, you should use the placement screen. Use this checklist to determine which steps should be taken. Is the placement signal flattened, as shown here? Is the controller issuing an alarm that the Impella device position is wrong? If this is the case, the cannula is either fully in the ventricle or fully in the aorta. Reduce to P2. Use fluoroscopic or echocardiographic imaging to determine the position of the catheter and reposition it accordingly. Is the placement signal pulsatile with values below 0? Is the controller issuing an alarm that the outlet is blocked? If this is the case, the outlet area may be on or near the aortic valve, and the catheter may be too deep in the ventricle. Or, if you are using the Impella LD device, the outlet may be blocked in the graft. Use fluoroscopic or echocardiographic imaging to determine the position of the catheter and reposition it accordingly. In instances in which there is low native heart pulsatility, the controller may not be able to determine whether the Impella device is correctly positioned. The placement algorithms require a minimum amount of native cardiac function to generate a pressure difference across the aortic valve. When native function is depressed, the Impella catheter will continue to provide up to the maximum amount of forward flow. However, the placement signal may be pulsatile with dampened amplitude due to low aortic pressure and depressed cardiac function. The motor current signal may be dampened due to the small pressure gradient between the inlet and outlet areas. The home screen may display a yellow question mark on the heart icon and the message, Impella device position unknown. In cases of low native heart pulsatility, monitor the position of the Impella device using patient hemodynamics and periodic echocardiography. If low pulsatility is due to decreased native contractility, or if the Impella device is completely unloading the left ventricle, this alarm may be triggered even though the Impella device position has not changed. Position monitoring in this circumstance is unreliable. Note, if flows are higher than predicted for the current performance setting, this may indicate incorrect position caused by catheter migration. Echocardiography can verify Impella device position if migration is a concern. If placement signal on Impella 5.0 or Impella LD becomes unreliable, a flow estimate will be provided based on the patient's mean arterial pressure. Determine what the MAP is on the patient's arterial line and correlate to the table shown in the flow estimate area. If the MAP falls in between the areas listed, estimate between the flows displayed. For example, if the patient's MAP is 90, the flow will be somewhere between 4.1 and 3.6 liters per minute. Echocardiography is one of the best tools for evaluating Impella position outside the cath lab. Long-axis transesophageal echocardiography. TEE, and parasternal long-axis transthoracic echocardiography, TTE, provide the best views of the Impella catheter in the left ventricle. The images shown here depict correct Impella 5.0 and LD device placement. Refer to the instructions for use manuals for images of incorrect catheter placement. This is an actual parasternal long-axis view of a well-positioned Impella 5.0 catheter. Note that the inlet area is approximately 3.5 centimeters below the level of the aortic annulus. The tip of the catheter pigtail is clearly seen in this case. The inlet is visible at the end of the double white line, that is the signature of the nitinol wrapping on the cannula. The outlet of the catheter should be positioned well above the aortic annulus. In this echocardiographic image, it is clear that the Impella catheter is very far into the left ventricle. The outlet area of the catheter can almost be seen at the level of the aortic valve. In this position, the outflow of blood immediately comes into contact with the aortic valve leaflets, and blood is likely to escape beneath aortic valve and end up inside the ventricle. This blood appears as turbulence in the left ventricle during the entire cardiac cycle. If the outlet area of the Impella catheter is too close to the aortic valve, colored Doppler echocardiography reveals jets of blood, creating a mosaic pattern in the left ventricle which resembles aortic insufficiency. Closer inspection, however, reveals that the outflow is occurring at the valve, which may be directing blood beneath the valve. An Impella catheter in this position can trigger a blocked outlet alarm, and the high shear forces on blood ejected into the aortic valve leaflets in this way can damage blood cells. In this echo, when colored Doppler is added, the flow of the device is seen below the aortic valve, indicating that the outlet area of the Impella catheter is too close to the aortic valve. Echocardiography is useful in many situations following insertion of the Impella catheter. It can be used in the cath lab to confirm fluoroscopic positioning, and it should be used again after moving the patient or any time you suspect that the Impella catheter position may have changed. Echocardiography is also useful if the controller displays an alarm stating that the catheter is incorrectly positioned or if you suspect hemolysis. Echocardiography can also help document left ventricular recovery during weaning. Suction can cause lower than expected Impella device flow, and patients may not receive the full benefit of Impella support. Suction may occur if the inlet area is incorrectly positioned in the left ventricle. For example, if the catheter is too far in the left ventricle, or if it is lodged in the papillary muscle, blood flow to the inlet area may be restricted. Suction can also be caused by inadequate filling of the left ventricle due to poor right heart function, inadequate volume status, or obstruction. The information on the placement screen can also be used to detect suction. To watch for signs of suction, monitor position alarms and note lower than expected flows for a given flow rate. The 5-minute timescale display may show reduced mean motor current. In addition, the patient's blood pressure may be lower due to the reduction in Impella output. If a suction alarm is present, reduce the performance level until suction is released. Confirm adequate volume status and evaluate Impella catheter position using the placement and motor current waveforms, as well as imaging. Reposition the catheter if necessary. While assessing the position with echo, confirm right ventricular function. Several conditions could lead to a low volume status. These include administration of diuretics, dialysis, bleeding conditions, and when a patient is on a VA ECMO. The Impella catheter does not cause hemolysis if the patient has adequate filling pressures and the device is positioned correctly. If signs of hemolysis are present, it could be from an obstruction in one or more of 3 parts of the Impella catheter. 1. An inflow obstruction. If there are ventricular structures such as papillary muscle obstructing the inflow windows, blood will flow faster through the unobstructed windows. High speeds against the cannula and other structures cause high shear forces and hemolysis. 2. An obstruction within the cannula itself, such as a fiber or clot. This creates narrowing of the cannula, creating shear and hemolysis. 3. Finally, an outflow obstruction. If the aortic valve or the aortic wall itself is obstructing the outflow, this will cause an increase in turbulent flow, causing shear and hemolysis. Red urine may be a sign of hemolysis, destruction of red blood cells. Hemolysis may be caused by mechanical forces generated by medical procedures or devices. There are, however, other possible reasons for excessive red pigment in the urine, including blood in the urine, myoglobinemia, and rarely metabolic conditions. Urine may be red due to the presence of red blood cells from urinary tract trauma. Urinalysis and plasma-free hemoglobin tests can be used to confirm or rule out hemolysis. Another reason for red urine is the presence of muscle pigment or myoglobin. Large amounts of myoglobin may be released during the process of rhabdomyolysis or muscle death, or when muscle is subjected to excessive pressure and is adequately nourished. This can happen when a patient has an ischemic limb with tissue loss. Rarely, red urine is caused by metabolic conditions, such as transfusion reactions and drug reactions. Once these conditions are ruled out, the likely cause of red urine in a patient on Impella device support is hemolysis due to incorrect catheter positioning or low volume. Add volume if hemolysis occurs with central venous pressures or pulmonary capillary wedge pressures below 10 millimeters of mercury. The pressure sensor on the controller reads purge pressure from the purge disc and automatically adjusts the purge flow to keep the purge pressure within the specified range. The automated Impella controller issues warnings if purge pressure is too high or too low, or if it detects a blockage. While caring for a patient with an Impella device, it is important to account for the heparin that is delivered through the purge system. This dose can be found on the automated Impella controller by switching to the infusion history screen on the display menu. An ACT of 160 to 180 seconds is recommended for all patients while on Impella support. For some smaller patients, this ACT may be achieved by just the Impella-delivered heparin, requiring no additional systemic heparin to be delivered. For the first 24 hours, it is recommended to monitor ACT levels every 3 hours. In situations in which excessive heparin is being administered through the purge system, it would warrant the reduction of heparin. As always, the Abiomed Clinical Support Center is available to answer any questions regarding the Impella-delivered heparin. The infusion history screen displays the infusion volume as well as the amount of heparin and dextrose delivered each hour. This is calculated based on the concentrations that are entered by the user and the purge flow rate. The current time period is displayed at the top of the list. The calculations begin when the case start procedure is completed and the flow rate is greater than 0 liters per minute. It is important for the caretaker to account for the heparin being infused by the Impella system into the total heparin patient dose. To help with determining the amount of systemic heparin that is required to achieve the ordered heparin dose, this tool was developed. To determine the Impella-delivered heparin, multiply the heparin concentration dose by the purge infusion rate. This can also be found already calculated on the infusion history screen. This is then subtracted from the ordered IV heparin dose received from the physician. The difference is the amount of heparin that should be delivered systemically. If the purge pressure is greater than 1100 millimeters of mercury and the flow rate is below 2 milliliters per hour, the AIC will alarm high purge pressure. Here is the checklist to review in this event. Check for kinks in the purge tubing or anywhere along the catheter. If visualized, straighten the tubing, sidearm, or catheter. Second, check the purge solution to ensure that D5W is being used. In the event it is not, the concentration should be lowered to D5W with heparin. If unable to resolve a high purge pressure alarm, monitor the motor current for increases, which can indicate impending pump failure. If the purge pressure is below 300 millimeters of mercury and the flow rate is 30 milliliters per hour, the AIC will alarm low purge pressure. Here is the checklist to review in this event. Check for any leaks in the purge cassette or the lower connections to the catheter. If visualized, tighten the connection. If a leak is visualized from the purge cassette, replace it with a new one using the Change Cassette and Bag feature under the Purge menu soft button. If leaks are not noted, attempt to resolve the alarm by increasing the dextrose concentration to D20 in water with heparin. Increasing the dextrose concentration will lead to a higher viscosity of fluid, which may help the low purge pressure. If unable to resolve a low purge pressure alarm, monitor the motor current for increases, which can indicate impending pump failure. If a patient on Impella heart pump support goes to the operating room for cardiac surgery, the surgeon could elect to remove the Impella catheter completely from the body, pull the Impella catheter back into the aorta, allow for partial bypass while on support, or leave the device across the aortic valve while the aorta is cross-clamped. If the device is pulled into the aorta, it should be maintained at P1. Placement monitoring can be disabled so there are no placement alarms. Should the patient remain on Impella device support while on partial bypass, turn down flows if necessary to avoid any suction events. If the Impella device is left across the aortic valve while cross-clamped, the Impella device flow needs to be turned off. However, the purge needs to be maintained. This is achieved by activating surgical mode on the AIC. Surgical mode is used to silence the Impella stopped alarm when the P level is reduced to P0. To enable surgical mode, set the P level to P0. Select the Menu soft button, then Settings Service, then Enable surgical mode. To disable surgical mode, increase P level above P0, or select the Menu soft button, then Settings Service, then Disable surgical mode. When caring for a patient supported with the Impella 5.0 device placed in the axillary artery or LD catheter, perform dressing changes per hospital protocol using aseptic technique, and be careful not to pull on the Impella catheter when transferring a patient from one bed to another. For patients supported with the Impella 5.0 device inserted via the femoral artery, do not raise the head of the bed to higher than a 30-degree angle. Assess the vascular access site for bleeding and hematoma. Use a knee immobilizer as needed to maintain the access site straight. Monitor pedal pulses. The Impella catheter is designed to be operated with heparin in the purge solution. Lab experience reveals that heparin appears to protect the Impella device motor. If clinicians suspect heparin-induced thrombocytopenia, they should verify it by a positive ELISA test and positive serotonin release test. Many experts believe HIT should not be diagnosed unless megakaryocytes are present on peripheral smear.
In patients with heparin-induced thrombocytopenia, clinicians should remove the heparin from the purge. While monitoring the purge system, if a decrease is seen in the purge flow to less than 3 milliliters per hour, physicians can consider the use of TPA, which can be accessed by contacting the Abiomed Medical Affairs Department by visiting the link shown here.
Monitor patients being supported with the Impella device for signs of right heart failure. Look for reduced flow from the Impella catheter, suction alarms, elevated filling pressures, signs of liver failure, reduced PAPI score. If a patient exhibits any signs of right heart failure, consider standard of care treatment. Cardiopulmonary resuscitation should be initiated immediately. if indicated, for any patient being supported with the Impella catheter. When performing CPR, reduce the Impella device P level to P2. Once cardiac function has been restored, return the P level to the previous level after confirming a pulsatile motor current. An echo should also be ordered to confirm proper placement. If defibrillation is required, there is no need to make changes to the AIC. When weaning a patient from Impella support, reduce the flow rate by 2 P-level increments as cardiac function allows. Do not decrease P level below P2 until just before removing the catheter from the ventricle. Once patient hemodynamics are stable, the patient should be taken to the operating room for explant. Once ready to remove, drop to P1 and pull the catheter into the aorta. Reduce the P level to P0 and remove the entire catheter. The graft should be ligated and the site surgically closed. For additional information, training